This is Dr. Hannah Galvin, here to talk to you about the SHIFT Collaborative. The SHIFT Collaborative has a mission to advance safe and patient-empowered sharing of health information for all. Our vision is to further a healthcare ecosystem in which better technology for clinical data sharing increases trust between all members of the care team in order to improve health quality and outcomes. SHIFT is a big proponent of interoperability. Over the last 15 years or so, we've really built out the interoperable ecosystem so that data sharing has become commonplace. We are now sharing data across healthcare entities and with multiple other actors across the ecosystem. This has been driven by a number of regulations that have really supported the sharing of health information. These regulations have been pretty successful. We now have many and most office practices, as well as acute care hospitals, sharing information and doing it quite well. As we move forward with the Trusted Exchange Framework and Common Agreement, we'll advance these pipelines and accelerate the sharing of health information. The leaders of SHIFT have been really involved in the development of these pipelines and frameworks, and we recognize the potential to really improve the quality of healthcare, the delivery of healthcare, as well as the reduction of costs as we're able to share healthcare data more easily and decrease burden as well. However, we feel that it's really important, and we've discovered and understand how important it is to be thoughtful about the way that we share data. I am a practicing pediatrician, and I'll tell you a story about how this has impacted me in my practice specifically. This is a young man that I saw when I was doing street medicine. This is a picture of the van where I used to do street medicine, and this is a 21-year-old young guy who was hit by a truck. And when I saw him, he had bruising on his chest and his abdomen, and I wanted to send him to the emergency department. And he didn't want to go because he had a history of substance use disorder. And when I tried to send him to the emergency department, he said, you know, they get my record ahead of time. They open my record and they see that I had a history of substance abuse disorder, and they say, you're just drug seeking. They don't believe that I actually need care. And he had a lack of trust in the system that was sharing his data. And so even though I was working to help build out these pipelines of data sharing, I recognized that my patients were not always benefiting from this data sharing, and in fact were worried about seeking care because of the data that preceded them. Here's another patient example. This is a mom who shared with her pediatrician the information, the very sensitive information, that she was having trouble meeting her family's costs and getting food for her child. The doctor made notes in her record, and that ended up on the portal where the child's father found that information. And that father used that information against mom in a custody battle and got custody of that child. So mom doesn't feel very safe sharing that information with a provider who could help her get resources that would help care for her child. And we know that those health-related social needs are really, really important and essential. But in these types of cases, families often don't feel comfortable sharing that information because of the potential consequences. A couple of other examples for you. This is a young graduate student who came here as a young child from another country, and he's working to try to gain legal status here, but he's afraid if he comes in for care and his immigration status is documented as it's required, as is required in some states, this could be identified by law enforcement agents, and he could be detained. So he expresses fear about coming in for care. Many of the patients that I work with currently are expressing that type of fear given the current climate. A couple of other examples. We've seen that individuals who are suffering from intimate partner violence, both male and female, are very concerned about what gets documented in their record, and rightfully so. right? If I, as a clinician, document the ICD-10 code or the diagnosis code for intimate partner violence, which is something that I may really want to document in the record so that other providers know that this patient is at risk. If they come into the emergency room with bruising, we should know that they're at risk. This could then go to the payer, to the insurance company, and the partner may be the guarantor on the insurance and could see that code, and that could perpetuate the cycle of violence or escalate even the cycle of violence. So that could really be a risk factor and a safety issue for that patient. A couple more examples, right? Some people that we might not even think of as potentially having sensitive data or concerns about their data. This is an older gentleman who has a history of alcohol abuse and is also currently taking an erectile dysfunction medication. His adult daughter is helping him to get to some of his appointments, and he is fine with his doctors having access to this information, but he says, I don't want my adult daughter to know about this personal information in my chart, right? I want to keep that personal. I want to keep that private. And I do want my daughter to know about my appointments and help me to get to my appointments, but I don't want to share some of this information with her that feels uncomfortable to me. And finally, one more example, right? This is a woman who legally terminated a pregnancy in a state that allows that, where that's legal, and now she's going to another state where that is illegal and where that information could be used to prosecute her, where that information could be criminalized. She is very concerned about the fact that if she ends up going to an emergency room or an urgent care center in that state, that she would want some of her medical information to be transmitted so she could get the best care, but she might not want that medical information transmitted because she's worried about the fact that it could be used to criminalize or could be criminalized in that state. So how can we enable that? And we actually see that this is not all that uncommon these days. This is relatively common. We are hearing more and more and more of these stories where patients are telling us we need a better system to protect their sensitive data, and sensitive information may be what is protected by federal law and may be defined by state law, and increasingly we're seeing states define sensitive data by various shield laws, and the states define this differently. Different countries are defining sensitive data differently. So it's not just here in the US, but sensitive data may just be what I define as sensitive, right? If I am Patrick Mahomes and I am playing football, I'm a professional football player here in the US, and I have a knee injury, that could be sensitive data for me, whereas right, for somebody who's not a professional athlete, that might not be particularly sensitive data. So sensitive data is very subjective, and what we hear increasingly is that patients want a way for us to protect their sensitive data, whatever that means to them. We do hear that those patients who have been historically marginalized, who are more vulnerable, are disproportionately impacted by this, and that their trust is fragile and needs to be protected, and that they already mistrust the system, and that the protection of their sensitive data is key to regaining or gaining some trust in the system. Here's some data that supports this. We see this is a study that was done a couple of years ago through the American Medical Association, and we see that patients are much more comfortable sharing data locally with their doctor's office than more broadly with a larger hospital or health system or with local media sites or social media sites and big tech, as might be imagined, because they have that trust relationship with their doctor's office. Concerns about sharing data and concerns about the adverse use and people misusing data are much higher in historically marginalized populations, specifically in ethnic and sexual minorities. Most people who were surveyed as part of this study want the ability to opt out of sharing some or all of their health data and have some control over doing so. When we talk about social needs data, so health-related social needs, a majority of patients report some discomfort that providers are sharing that social needs data. And this is more common when patients have recently experienced a social need, or if they more recently had a poor quality of care experience, if they have decreased trust in the health system, or if they've experienced discrimination. So we see that patients who have had these types of negative experiences with the health system, or if they have actually had difficulties and have had health-related social needs, they're less likely to be comfortable sharing that information. What this tells us is that many of us who are making these decisions at a policy level or at a technical level, that it's a great thing to share the social needs data. It is a really good thing. It is helpful for me as a physician to know if a patient is having housing insecurity or transportation insecurity, but we need to be really cognizant of a patient's lived experience, and that may not be exactly what they want, right? They may have concerns about it, and we need to be really mindful of those concerns, in addition to understanding how helpful it can be for us to have that data. We need to understand the mistrust that goes along with that, and that sharing that information indiscriminately without any control, without giving the patient any control or any choice, can be really potentially harmful. Here's some data from the state of Florida. In the year 2023, the state of Florida enacted a law that required hospitals to ask patients about their immigration status and record their immigration status. And we saw over the following year that Medicaid emergency coverage for immigrants decreased by 55%. What that means is that when immigrants went to those hospitals, they were asked about their immigration status, and immigrants said, you know what, I'm worried about that. I'm worried about that information being shared, and I'm just not going to seek care when I need it in an emergency. We see that across the board. When patients say, hey, I have some sensitive information that I don't want to share, I'm just not going to seek care when I need it. Like my patient on the medical van, he's just not going to seek care. He's just not going to go to the emergency room if he needs care, right? In other cases, patients are seeking care, but they're not disclosing important information. They'll go in and they'll say, you know, I'm not going to tell you everything because I'm worried about how that information is going to be used. We know that medical mistrust has existed for a long time, and it continues. It is higher in historically disenfranchised populations for good reason. It is associated with decreased compliance with recommended care, with recommended screenings, with follow-up care. Most recently, with the COVID-19 pandemic, we've seen vaccine hesitancy and lower vaccination rates in racial and ethnic minorities, and this has been correlated with higher levels of medical mistrust. This is a known phenomenon, and it's really an important one for us to understand that if patients continue to feel, and individuals continue to feel like we are taking their control away from them, this medical mistrust will continue to be perpetuated. These are some additional patient perspectives. Open Notes has done some focus groups, and they have asked patients, right, what do you want providers to ask you about? And here we see, right, that patients want to be asked about a number of sort of health-related social needs, but they also have some differing opinions. For some patients, sexual orientation is something that is really important to them to be part of their medical record and to be asked about. It's part of their identity, but just as many patients said, you know what, don't ask me about that. That's sensitive to me, right? That's not something I want to be asked about or don't want to be shared in my medical record. So we see here from this data that some of these areas that we commonly ask about in health visits are sensitive and subjectively sensitive to some patients, and yet a key core part of people's identity for others. These are some other quotes from the Open Notes focus group, right? There are concerns that You don't know who is getting your information, right? That if it's not relevant to the care I need, I don't think it should be shared, right? I don't want my provider to be biased, right? I don't want anybody to base my healthcare off how much money I make or anything like that. And I want to know, right, if this information is being shared, right? I want some transparency into that. Patients are concerned about how this data is being shared, so they would like to designate what can be shared and with whom. These are some of the summary points from that open note study. They only want that relevant information to be shared, and they're concerned about that bias. Some of the other things that came out is that people really don't understand, and we know this, people don't understand what they're signing when they sign a consent, right? They don't understand how their data is being shared, and they don't want information shared with people who they don't trust or who rarely see them. The Pew Charitable Trust did a similar series of focus groups across the country, across the U.S. Around the same time, and they had sort of similar or similar findings, right, that patients want access to their medical records and they want to have some control over how their records are shared. Particularly, racial minorities noted that they were worried about that access and who could see their personal information. There was a concern about this, that people would prejudge them, that they would have bias, that it would negatively impact their treatment. Again, here are some quotes from that study, right? I'm worried about people prejudging me, and I'm worried that if somebody knows that, right, that I don't get that decision point, right? If I want somebody to know, I can tell them, and so those are just some points. Now, here's the problem: we have some technical limitations in doing what patients ask, right? What patients are asking us is to let me as the patient decide who to tell about my sensitive information. But the way our technical system works today, if I don't have any sensitive information, however that's defined, and I end up, say, in the emergency room, in the hospital, all of my data can flow because we've spent all of these years building out this interoperable ecosystem, which is great. My problems, my meds, my allergies, all of that information can flow. And the emergency room provider, that hospital provider, can provide me the best care possible with all of the work that we've done to build out interoperability in this country. Same thing if somebody's helping care for me and helping me get to appointments. My portal proxy is helping me, that information gets to the patient portal. But if I do have sensitive data, we have very limited ability to turn that data on or off, right? So, and turn sharing of that data on or off, right? So if I don't want to share that piece of sensitive data, most of the time, all I can do is turn off all data sharing or most data sharing for myself. So if I now end up in the emergency room, that emergency room doesn't have any of my data. It doesn't have my problems, my meds, my allergies. Sometimes that's done for me algorithmically. If I have if I have a history of substance use disorder, right, my organization may say, under the federal regulation, we cannot share your data without an additional consent. And so we are going to shut off data sharing for you so that we can be compliant under the law. And now I show up in the emergency room, and without some additional consent, which maybe I'm not able to sign if I'm unconscious, or I don't want to sign because I don't want that data shared, right? None of my other data can flow. And now I'm not getting the same care. I'm getting materially different care, and I would say materially lower quality care than the patient without sensitive data. So we are inadvertently creating disparities here between patients who have sensitive data and patients who do not have sensitive data. This is the foundation of what we at Shift sort of call equitable interoperability, or more equitable interoperability. At Shift, we are working to ensure that all patients, regardless of their health conditions, regardless of what data they consider sensitive, can benefit from seamless health data sharing. We want interoperability to work for everyone. We want to give patients control over what they share and ensure that providers have the right information to safely deliver the best care in the appropriate situation. So going back to that Pew study, what Pew recommended was that ONC, which is now ASTP, the Office of the National Coordinator for Health IT, now called the Assistant Secretary for Technology Policy, should continue to accelerate patients' access to records, but they should really focus on tools and policies that would enable the exchange of individual data elements, or what we call granular data segmentation, through standards-based APIs. And you might ask, why hasn't anybody done that? And they have. We've had some pilots in previous efforts around standards-based granular segmentation. There's a standard called DS4P, or data segmentation for privacy. It's as old as, it's almost a decade and a half old now. It dates back to 2011. And there was a clinical document architecture, or CDA, version of this, and it was piloted at a number of sites. There is now a FHIR version of this, and there are some IHE, or Integrating the Healthcare Enterprise profiles based on this. There have been some consent management tools supporting this as well. So here are just sort of a slide showing some of the efforts that have gone on in the past. So why hasn't this taken off? Why has this not become more widespread? One of the reasons is that the initial pilots really focused on mostly a single use case and a couple other niche use cases. They mostly focused around substance use disorder, and not all substance use disorder cases, but federally funded substance use disorder clinics, or 42 CFR Part 2, that 42 CFR Part 2 regulation. They didn't leverage some of the advanced tools. They mostly stayed kind of at the document level and didn't look at how you could segment data at the element level. They focus on just single systems. So how could we do this within one system? We didn't sort of plan for how could we do this between systems in an interoperable manner. There wasn't really a value set to define what we mean by common types of sensitive data. SAMHSA had developed a value set, but they stopped maintaining it after 2016, and that value set was mostly focused again on substance use disorder. So there isn't sort of a nationally maintained value set through the National Library of Medicine Value Set Authority Center. And so if I talk about, say, reproductive health data here in Boston, and somebody in California talks about reproductive health data, how do we know that we're saying the same thing? We don't right now. And so that is a real limitation. And then there are a lot of controversial issues which make this really difficult and have resulted in us sort of kicking the can down the road as an industry. One of those issues is, how do we balance patient privacy with patient safety? For instance, if I said, I don't want to share my behavioral health data, like my depression diagnosis or my depression medications, with my podiatrist. And then my podiatrist goes ahead and prescribes a medication that could interact with my SSRI, my depression medication that I'm on. What do we do about that, right? How can the podiatrist practice safe care, right, when this information has not been shared with them, right? Is that appropriate, right? Is it still my right to not share that information with them? How do we handle this, right? If too many people don't share their information, ultimately we get biased data sets. How do we handle that, right? There are a lot of really challenging questions to answer, and for a long time we've said, that's just too hard. We're just not going to touch this at all. But when we do that, we continue to perpetuate these disparities. So when we think about it, part of why this problem hasn't been solved is that technology is only part of the solution. We really need to understand sort of these socio-technical pieces, right? The implementation and some of these implementation questions need to be informed by lots of different stakeholders. There are technical pieces to this, places where the EHR vendors and the standards development folks really need to weigh in, where we need terminologists, where we need ethicists and privacy experts, where we need interoperability experts, where we need patients at the table to understand, hey, what do patients understand about this and how their data is their data is shared. And these stakeholders need to come to consensus around some of these key issues that are really pretty controversial right now. In the process, there are a ton of nuances and edge cases that are pretty easy to get lost in, and so those can sort of derail the conversation. And until recently, the past few years, there hasn't been a lot of alignment on how urgent it is to solve this problem. More recently, there has been more urgency related to some of the legislative changes and overall sort of climate concerning cybersecurity and real concern over sharing of data and security of data and privacy considerations. So what is SHIFT? SHIFT is an independent, nonpartisan collaborative dedicated to advancing safe and patient-empowered information sharing, health information sharing. We were founded in 2018. We are volunteer for the most part. We have a small amount of grant funding at this point. And we have experts across the health IT industry, across verticals, policy, privacy law, patient advocacy, the interoperability space, standards development. And we work to break down this sort of all or none barrier, the multiple barriers, in a way that are trying to work toward more equitable interoperability. We focus on patient autonomy. We look at robust technical standards and open source solutions, as well as practical guidance for real-world implementation. This is a community-driven effort, and we want to ensure that everybody can access the benefits of interoperability and health data exchange while respecting individual privacy choices. SHIFT's work is driven by a shared understanding, an understanding of the need for equitable interoperability, that if we continue to kick this can down the road, we're going to continue to worsen disparities, and that the opportunity cost is going to have the most severe impact on the most marginalized and historically marginalized, underserved, and vulnerable patients and communities. And it's important to make sure that these communities are at the table talking and thinking about solutions with us. As I mentioned, the recent legislative measures and their cybersecurity concerns have underscored the urgency of solving this problem now. Here's our team. You see me. I'm the SHIFT co-founder. I'm the board chair. My day job is as Chief Health Information Officer at Cambridge Health Alliance, a public academic health system in the Boston area. I am on the faculty of Harvard Medical School and Tufts University School of Medicine, and I'm a practicing pediatrician. This is the rest of our leadership team, and our board consists of the American Academy of Pediatrics, the American Medical Association, Drummond, which is a group that certifies many of the electronic health record vendors, the HIMSS Electronic Health Record Association, which is the professional body for electronic health record vendors, Integrating the Healthcare Enterprise USA, which is a standards development organization, and the Assistant Secretary for Technology Policy, the Department of Health and Human Services Assistant Secretary for Technology Policy, which has sat on our board for a number of years in an ex officio non-voting status as we try to stay in lockstep with HHS and policy changes and provisions and the sort of state of interoperability in the United States. SHIFT's approach is to be an inclusive collaboration of expert stakeholders. Right now, we have about 300 stakeholders from across verticals, as I stated, to be patient-centered. We are vendor-neutral. We are nonpartisan. We are focusing on high-impact use cases first. These are use cases that have been vetted by the community and prioritized. We're building on existing frameworks and existing technology. We are not developing a product. Everything that we are working on is open source and there for the community to further develop on. We're looking at proof of concept and then allowing the community to develop from there, encouraging the community to develop from there. In terms of implementation, we are using the Delphi method, which is a mixed methodology research process where you bring a bunch of experts together, you ask them a bunch of challenging questions about a topic. They provide their answers. You allow them to discuss their answers. They answer the questions again, and you try to move toward consensus so that we can try to move the industry toward some consensus recommendations in areas where we've been stuck for a really long time. We are working and building sequentially toward real-life implementations, and as I said, we bring together multidisciplinary expertise. Here are Shift's clinically informed use cases. Right now, we are in phase 1. We have built out an older adult behavioral health use case that focuses both on substance use disorder covered by a federally funded clinic that's covered under 42 CFR Part 2, and not a non-federally funded clinic, as well as other behavioral health data. We also have an adolescent reproductive health use case, both for a minor and an adult, someone over 18, that focuses on reproductive health, sexually transmitted infection, abortion information, and gender identity. And we have added immigration status to that use case as well. Those are our phase 1 use cases. Our phase 2 use cases include adult social drivers of health data, and that is in collaboration with the Gravity project that has been working very diligently and has had a lot of success in building out standards around social drivers of health over the past number of years. And we are working with them to develop that use case involving both social drivers as well as intimate partner violence, and including sort of sharing of data with mobile apps there. And then we have a final use case in our second phase that includes commingled data in a mother and infant chart. When you deliver a baby, it's very important to me as a pediatrician to have mom's data in the baby's chart, right? And from an infectious disease perspective, there are a lot of other health there's a lot of other health information that's very important for pediatricians to have about mom because the baby was just exposed to mom. But there's a lot of sensitive information in there too, right? Mom's potential of sexually transmitted infections, if she had postpartum depression. And now that we have everybody on longitudinal medical records, or many people on longitudinal medical records, when that baby turns 18, they'll have access to that information, and mom may not want the baby to have access to that information. Also, the other parent may have access to that information through the baby's portal. And so there are a lot of privacy considerations there too. And so that's the other use case in phase 2. This is how Shift is structured. We have 3 work streams working simultaneously and together collaboratively. Our technical work stream is building out reference implementations of increasing complexity in a FHIR sustainable sandbox that we have developed. And that is in collaboration with the HL7 security group. Our technical lead is the lead of the HL7 security group. We are also working to develop national semantic conceptual models for sensitive data, which we are also working together with HL7 in a cross-paradigm project to do that. And so both of those work streams are collaborating with HL7. Our implementation work stream is the one working on the Delphi project right now and the Delphi methodologies. And there are 4 of those Delphi processes that I will get to on the next slide. All of these work streams are informed by our advisory groups. We have a clinical expertise advisory group, an advisory group of legal and policy experts, one focused on ethics and equity to make sure that all of the work that we're doing conforms with principles of ethics and that we are doing all of this work in an equitable manner and focus on principles of equity. And then we have a group that we are working together with Open Notes to provide patient expertise and patient and caregiver partner expertise to all of this work as well. So that's how we're structured. Modified Delphi process in this for this phase is focused in these areas. We have first gone through a number of rounds focused on informed consent. What does informed consent look like if you are going to think about allowing a patient to redact data? What would that look like? What does a patient need to know, first of all, that, right, if you allow them and say you could potentially redact some sensitive data, you may not be able to redact all of that data, right? Some data may still be left in notes. Some data may be able to be inferred from other information in the chart, right? So what do patients need to understand about that? What do they need to be able to understand about the risks and benefits of being able to do that, and potential patient safety implications? So we wanted to work with the group to understand what would informed consent look like? What information would a patient need to know? The second Delphi process has been around the safety and ethics of redaction. If a confident, informed adult, informed by the informed consent from the first process, did say, I do want to redact certain types of data, is that safe to do based on sort of standardized principles of patient safety? Is that ethical to do based on sort of standard principles of medical ethics, and have the group sort of opine on that? So that was the second process. The third process was, okay, if an informed, competent adult patient did redact that data, what should the intended recipient see on the other side in a variety of situations? Patient portal, EHR, right, an ACO care manager, if there was de-identified data being used for population health data analysis, for a payer, for instance, or in a third-party app. So we looked at a number of different situations. What should the recipient see? Should they see that there was some data that should be there? Should they see what kind of data should be there? Should they see that at the document level, at the section level, right? What should they see? So that those are some of the questions that we tried to answer, and we'll be publishing these results. And then the fourth topic that we're going into soon is about how any potentially redacted data would be used in decision support interventions and in training AI and machine learning models, right? If we say, hey, you can redact that information, how should that be used in a drug-drug interaction alert, for instance, or should it be used? How should that be used in aggregate in training some type of AI model? And so we'll be watching into that as well. So all of this data and this information, this expert guidance, will be published both in peer-reviewed publications as well as in a companion implementation guide as well. Our terminology work group is in, or our work stream is in collaboration with the HL7 cross-paradigm sensitive data and sensitivity flags library and guidance project. So we're working together there, and we'll be developing an open source library that's shared and maintained as an industry-wide repository here around sensitive data, starting with jurisdictional privacy rules. Some of the state jurisdictional privacy rules. I think the hope is that states won't need to come up with their own value sets going forward, because we'll have a national library of value sets, or a national library that they can look to. And so individual states won't need to define this themselves, which makes it really hard for the vendors to keep up and develop technology that is state specific. It also makes interoperability really hard if every state defines different types of sensitive data their own way. So we'll be working toward that, and we are working toward that. Our technical work is using the DS4P FHIR standard. The way that the DS4P FHIR standard works is it enables security tags so that you can apply security tags to data elements, structured data elements, yes, but also eventually unstructured data elements based on the value sets that we are developing, and tag those data elements as sensitive or with different types of sensitivity. Then we would apply consent management. So a patient could say, I don't want to share my reproductive health data or some specific type of reproductive health data, like my abortion data, with this entity or this individual, right? And there would be real-time enforcement of those types of rules. In order to enable this, we have this FHIR sustainable sandbox, and we are building out sandbox demonstrations of increasing complexity. So first, we're just applying the security labeling, and we're doing that in a demonstration of data sharing between the EHR, so an electronic health record, and a health information exchange, as well as an electronic health record and an electronic health record. So sort of two different demos, right? EHR to HIE and EHR to EHR. So we're just showing first that the data can be labeled. And then we're showing the data transmission with the filtering of that data, and then how that filtered data is controlled in the recipient system. The next step is to incorporate the patient preferences. So we'll apply the consent decisions, sort of mock consent decisions. We'll say, right, the patient does not want to share, say, their abortion data, right, according to our use cases, and how will those be applied? The next step is to integrate with a consent management engine. And there are some out there already. There are a few commercial ones. We are working with open source technology. So we are looking for an open source, and we'll build upon an open source consent management engine to demonstrate that a patient can dynamically enter how they want to share or not share data, as well as revoke that consent when they want to. And so we'll demonstrate those. That is all in preparation for future real-world demonstrations. So we're building on from sort of simple to more complex, and eventually to get to real-world demonstrations. This is what the security labeling service looks like in terms of architecture, for those of you who are more technical and would like to see that. And this is how it then fits in to the overall architecture with the security labeling service sort of down at the bottom, fitting into the overall architecture with the consent management service up at the top right, storing the consent in a FHIR consent store, and the consent enforcement right there in the middle between the EHR and the recipient. If you'd like to get involved in SHIFT, we would love to have you. There are multiple ways that you can get involved. You can share your time and expertise with us in one of our work streams or advisory groups, or both. You can share what we're doing with others. Please let people know about what we're doing. We are specifically looking for more patient advocates and a patient advocacy organization. We are a national patient advocacy organization to help join us. We have had a national patient advocacy organization on our board in the past, and we are looking for one to join our board in the future. We are looking for additional funding opportunities. As I mentioned, most of our work is volunteer. We have a few modest grants that supports this work, and the work can be done faster the more funding we get. We know that many individuals in this country and worldwide would like this technology available as soon as possible, and yesterday, if that were possible. We are only hindered right now by funding, and we would be very interested in working with anyone who could help us to gain additional funding sources. We're eager to collaborate in this regard. So those are some ways to get involved. Here's a QR code for our Join Us, the Join Us page on our website. If you use that or go to the URL at the bottom, there's a little form that you can fill out for ways to join SHIFT, including our large group meetings and signing up for our large group meetings, and to get involved. And then you can also follow us on social media.